Yeah. Okay. Good morning, everybody. It is April 14th, 2022. Our topic today is post-obstructive pulmonary edema. I'm just saying all this because it's recording, but Grace is going to start out. We also have Alex. So welcome them this morning. They're PACU residents for the week, 2 weeks. Hopefully it's been a good 2 weeks for you guys. Yeah. I can hide. Okay, make sure this is this view okay, or did you have notes? Like, did you need?
We did, but that's okay if we don't have them.
Okay, I can. Okay, this is down a little blurry. I'm not sure why. There we go. Okay. There, that's better. And if there's anything else you need to like swipe away or whatever, you can. But if you want to just switch back to presenter view, go ahead. Whatever's easiest. So. Okay.
So good morning, everyone. All right. Again, if you haven't met me yet, my name is Grace. I'm one of the CA1s, anesthesia. Been on the PACU rotation.
I'm Alex.
Yes. So we'll be doing a presentation today on post-obstructive pulmonary edema, also called negative pressure pulmonary edema. Okay, so to kind of get the wheels turning, to start thinking about this from a clinical perspective, we have a couple of cases to start. Just to kind of get our thinking in that direction. So for this first one, we have a young, healthy guy. He's undergoing a lap appy. The case itself is uncomplicated, but as we're starting to wake up, so the surgical dressing is being applied, he bites down on the ET tube that he had in. The ventilator alarms, it tells us we have high peak pressures, we have low tidal volumes, so we put a bite block in the OR. But it turns out he still desaturates shortly afterwards. We start to see secretions coming from his ET tube shortly after. And when we listen to him, it doesn't sound pretty. We get rales and rhonchi throughout all lung fields. So another scenario here. So now we have an even younger patient, a 10-year-old, and again, healthy, undergoing a tonsillectomy and adenoidectomy. The case itself and emergence are both uncomplicated, and the patient comes wheeling out here to PACU. Shortly after arrival, things start looking a little different, a little bit of respiratory distress. We see some desaturations to the 80s, signs of stridor, or no signs of stridor, excuse me, no signs of airway obstruction, but we are seeing secretions. We get a chest x-ray that's showing pulmonary edema, no evidence of laryngospasm or anything like that. We do secure the airway. So just two cases to kind of get us thinking in this direction. We'll revisit these later in the presentation and kind of talk about them after we've talked more about the pulmonary edema. So before we get into that, a little break here. I heard that you guys like dog pictures, but I threw in cat pictures here. This is Billy. She's my cat. She's a rescue calico. Got her about 2 years ago, and she is a lovable demon, is what I like to call her. All right, so talking here, kind of defining what the overall point of this presentation is, but it is post-op pulmonary edema, or POP, is a life-threatening airway complication that occurs due to a history of airway obstruction. You get rapidly developing respiratory symptoms, and this can occur in the intraoperative period, the postoperative period, or the significant postoperative period when they're away from hand PACU but in the ICU. And these often involve young, otherwise healthy patients. We have two types, which we'll talk about here in a second. And just for fun, since it is abbreviated POP, we have a picture of a POP here who's looking stressed because this is a significant life-threatening complication. So I mentioned there were two types. We have type 1 and we have type 2. So type 1 is the more common one. It's what we typically see. We typically see it happen. And this is a acute airway obstruction with then some forceful negative pressure or breathing in. And so this is kind of related to that first case that we talked about. The second type, or type 2, is a little less defined, but it typically occurs after relief of a chronic partial airway obstruction. So kind of thinking about that second case with the tonsillectomy and adenoidectomy that the kid had. So focusing on type 1 here, what are common causes? So anything that we can think about that causes acute airway obstruction. So the star here is by laryngospasm, as that is the most common and something that's related to the perioperative period, something that we see frequently. But anything on this list does cause acute airway obstruction, so breathing against that. So just kind of going through some visual representations of these. So here we have laryngospasm. So we see this being closing of the vocal cords due to some airway irritation, such that you cannot pass air through them. We have this pretty picture of epiglottitis right here, probably more commonly seen at Mott rather than here, but again, airway obstruction due to swelling of the epiglottis. Croup, we see that steeple sign right here with the narrowing of the trachea. So again, this is infectious illness, again, probably more commonly seen at Mott than here, but causing narrowing of the windpipe, which can become acute, and then you have your obstruction from that. Biting of the tube, another common thing that's specifically related to the perioperative period, but that is your conduit for air passage, is your ET tube. You bite down on that and suddenly you're obstructed, kind of like our first case. Here we see a mass, I'll kind of highlight it right here on radiology, which could suddenly cause acute obstruction. And then another thing here just being swollen tonsils. So again, there are other things mentioned here: strangulation, hanging, mononucleosis, but thinking kind of in like the perioperative picture and what we'd be dealing with here, we're thinking laryngospasm, we're thinking biting on the ET tube, things like that, more acute related to the PACU type setting. And then type 2, a little less defined, but this is anything where you have a partial obstruction and then it is removed, probably surgically. So, you know, like the first case with the tonsillectomy and the adenoidectomy, but also any tumor, like a goiter for a thyroidectomy, things like that. Hypertrophic uvula that's been removed. So again, something but a little less defined, and we'll kind of talk about this in a second. But before we get into that, just another quick break with pictures here. So I like to be outdoors and I like to hike. So just threw some pictures in here, me and my fiance and some of the parks we've been to. So Yellowstone, Badlands, and the Black Hills in South Dakota. So now to the dog pictures. But a little bit of background about post-obstructive pulmonary edema and the history. So it was first recognized in dog models in 1927. The dog pictures we have here hopefully do not have pulmonary edema, but these are my dogs. This is Bosco and Pepper, who are giving a visual representation of dogs. This wasn't seen in a case report until about 50 years later or so in a pediatric patient, and then an adult patient a couple years later. But the University of Miami did a retrospective study before they were really documenting these, and they found that there were about 30 cases that would classify as post-obstructive pulmonary edema in a 3-year period. So it's likely that we just weren't recognizing it or classifying it based on these definitions when it wasn't as necessarily common or as well known. So it's not like it just started in the 70s, but we started recognizing it around that time and became more and more well known as a complication. So this occurs in about 0.1% or every 1 in 1,000 of anesthetics. And it's typically seen again in young, healthy patients. They have the muscle mass to be able to breathe in, especially for that type 1, to create a strong negative force to create that pulmonary edema. It should be noted that the true incidence is likely higher than this 1 in 1,000. And this is just either because, you know, it's not reported as such. We don't get the classic symptoms, so we're not thinking that direction. It's type 2. Type 2 is a little harder to classify. So it's not as reported as often as the classic type 1. And it should be noted in patients where there is an airway problem anyway, so like an urgent airway is needed or an acute obstruction that we see the risk of pulmonary edema being much higher at around 11 to 12% here. But in the general healthy population where we don't have any urgent airway problems, we're looking at about the 0.1. So again, risk factors. So young, healthy patients. Looks like we did have a picture of the Michigan football team here, but I think someone changed that to something else. Yeah, I don't really recognize what's going on here, but again, that's because they can create that strong inspiratory force from their respiratory muscles. Other risk factors being problems with the airway, so difficult intubation, working surgically in the airway, causing swelling in the area, manipulation of your airway in the first place, obesity with sleep apnea, large amounts of narcotic use, anatomical variations in this area, short neck, things like that, acromegaly, and narrow trachea, things along those lines. So another break here, more pictures of me. I like eating. That's me at a really good restaurant I went to. Just some travel, my family and my sister. Okay, so kind of reviewing normal respiratory physiology before we get into the pathology of pulmonary edema. But looking at these two diagrams here, we have an inspiration and an expiration. Inspiration being an active act, so you are contracting your diaphragm, you're contracting your muscles, your intercostal muscles up here. Mostly the contraction of the diaphragm pulls down, you create a negative pressure in your lungs, which then from the strong atmospheric pressure drives air in. Expiration being a passive motion, you're relaxing those muscles, you increase your interlung pressure so the air goes out. So actively breathing in, passively breathing out, mostly using your diaphragm, but also using your intercostals and possibly accessory muscles should there be like a more need for stronger inspiration. Looking a little closer at this, I'm just kind of going over the pressures again, because this will come into play when we're talking about the negative pressure pulmonary edema. But starting with that top box there, looking at the intrapulmonary pressure. So we see with inhalation, we get a negative pressure, drives the air in, and then exhalation, a positive pressure, drives the air out. Intrapleural pressure, so between the actual lung wall and the visceral pleura, this should always be at least a little negative, otherwise you're looking at a pneumothorax type picture. But we see that we get a more negative, and then that comes up as you exhale. And then just tidal volume, as you would expect there, relating to our pressures, as you can kind of see correlated temporally on that chart right there. And then looking even closer at it, so getting our microscope and looking even further down, looking at the level of the alveoli, that little bubble right there being like one functional unit or alveolus of our lung. We say there's a combination of pressures that kind of create this balance for normal pulmonary physiology. So in the alveolus, if we think of it like a balloon, we have the air pressure inside pushing outwards, and we have the surface tension of the surfactant pulling inwards, creating a nice balance. And then in the capillary below it, we have our hydrostatic pressure pushing out, or the volume of the fluid pushing out, and our colloid or our osmotic pressure pulling in. We do have fluid around this system. So we have our interstitial fluid with lymphatic drainage. So anything that comes out of this under normal circumstances should be drained by your lymphatic system and pulled away from this to create this nice balance that we have of our pressures between these two systems. So under pulmonary fluid, most fluid is filtered out again through our lymphatic system that would come out of this. And the increased capillary hydrostatic pressure with decreased lung interstitial pressure results in a fluid shift into the interstitial fluid and around the alveolus. So kind of here we see our capillary, our alveolus, and then our lymphatic drainage right here, kind of showing things that come out from the capillary supposed to be drained away. And again, kind of looking back at that model that we saw earlier, the lymphatic drainage right here is what's emphasized on this. So another break here, some more dogs. So Bosco and Pepper are making an appearance again, my dogs. And then I like Michigan sports. I did go here for undergrad as well. That's me and my fiance at a hockey game. And then that's us in my hometown of San Francisco Bay Area in front of the Bay Bridge, the best bridge of the San Francisco Bay Area. All right, so pulmonary edema. So starting to get in some of the pathology. So we've kind of reviewed the overall normal pulmonary mechanics, but getting into some of the pathology of pulmonary edema. And so with this, we start to see fluid accumulation where it shouldn't be accumulating. So I think kind of starting with the visual representation here, we see normal alveoli, they're nice and clear, there's no buildup. But when you start to get pulmonary edema, we start to see these fluid levels here in our alveoli. And this has a number of implications, a number of problems that come with this. Most notably, gas exchange is disrupted. So the O2 that's coming out of the alveoli and the CO2 that's going back is disrupted with this, leading to hypoxia. Also leading to shock if it's severe enough. So, we get a backup of things. We can get cardiogenic shock or non-cardiogenic just due to hypoxia as well. And it should be noted that pulmonary edema can be rapid or slow in onset. So rapid being kind of what we're talking about here, where you get sudden increases in pressure, or slow due to gradual diseases that lead to an overall buildup. And the chest x-ray right here, kind of looking at the large volumes of fluid, kind of seeing it just looks like a wet chest x-ray from all the edema.
So going into the pathophysiology for type 1 being the more common of the two, it's all going to sort of generate and start with a sudden large inspiratory force against a closed glottis or obstruction. You're going to see decreased intrathoracic pressure, which is going to promote increased venous return to the heart. You're going to have increased pulmonary capillary volume, and then more hydrostatic pressure forces as well. So ultimately, you get a net movement of fluid from the capillary bed into the interstitium and the alveoli. And it's the same picture as before that Grace had on hers, but other mechanisms that are at work here are going to be the mechanical stress just from the inspiratory pressure damaging the capillary and alveolar membranes directly, and then fluid leaking from the capillaries into the alveolar spaces to worsen the conditions as well. My pictures now. So this is the picture of our family cat from a couple of years ago, and then that's him all grown up now. He's the sweet boy of my life. I'm team cat growing up, but I want a dog soon. And then this is my mom. She is a neonatal dietitian who is retiring later this month. Type 2 is the one that's not nearly as intuitive. It's going to be essentially what you have is a long-standing obstruction that you're essentially going to be having a constant auto peep to. So if you think of it almost as like a Valsalva, a low level of Valsalva, when you remove that obstruction, what you're going to see is a rapid decrease in intrathoracic pressure from its long-standing baseline, which is going to promote increased venous return, increased blood volume returning to the circulation, pulmonary capillary hydrostatic pressure as well, and fluid is ultimately going to be spilling out of the capillary bed and into the interstitium and alveoli. So going back to the cases, I'll give you guys a second to sort of read over this, same ones as before. So what one would this be an example of? Would this be type 1 or type 2? This would be type 1, yeah. And then going on to case 2, this is obviously going to be type 2. What would be other things that would be on your differential for these two cases? Common things being common. Like atelectasis would probably be up there, and we'll go into that, but that like aspiration pneumonia would be much higher than, without a good history of it. I think those would be things that would generally be considered before something like rare like POPE. But again, the differential is going to be very broad. A lot of it's going to be dependent on patient demographic, comorbidities, and then the surgery and how the course went as well. But things to consider would be things like aspiration pneumonitis, pulmonary embolism, anaphylaxis, iatrogenic volume overload, either type of pulmonary edema, and then of course POPE, sepsis, and ARDS. This is a picture of my fiance and I. So going into how we work up POPE, the first thing, again, it's going to be really hard to make a different diagnosis of POPE without a really convincing surgical history. Patient comorbidities are going to obviously play a part as well, but really what we want to know is, was there any concern for new or recent acute airway obstruction, as in the case of type 1, or for type 2, did we relieve a chronic obstruction that's now no longer there? Physical exam findings are going to be helpful, but you can see these in a lot of the other things that were on the differential. Tachypnea, hypoxia, agitation, all things that are pretty routine in the PACU setting. Crackles, rails will be helpful. And then pathognomonic is sort of the pink frothy secretions just from blood spilling into the alveoli and getting coughed up. Some studies that we can consider, blood gas is going to show hypoxemia. Chest x-ray notably is going to show diffuse pulmonary edema visibly immediately, whereas something like aspiration pneumonitis might take a couple of days to develop. It also can sort of tease out the just basilar atelectasis as well. And then if you're thinking of possible PE, you can order a CT scan, and then to rule out cardiac causes, you can do an EKG and an echo. Some recent vacation photos. This one is in Idaho. This one is in the Wind River Range in Wyoming. This is in southern Utah. This one was taken in North Cascades in Washington, and this is in Italy, pre-COVID. So ultimately, the treatment's largely going to be supportive. Most important thing, obviously, is of course to relieve the obstruction. We're going to maintain a patent airway, supply supplemental O's with positive end expiratory pressure. And then things also that you can consider if the patient began deteriorating, you could do mechanical ventilation with lung protective strategies, permissive hypercarbia, and low tidal volumes. Diuretics and steroids are kind of controversial. In a young, healthy patient, I don't think there's much harm in doing them, but the literature doesn't really suggest that. Diuretics are obviously going to be the staple of treatment in cardiogenic causes of pulmonary edema. And then steroids are also something to consider just to decrease inflammation in the alveoli. But again, it's just going to be based on the clinical picture. So the typical course, when it's recognized early, you can expect it to rapidly resolve within 12 to 48 hours, assuming we're using supplemental O's and PEEP right off of the bat. However, if it goes untreated for a prolonged period of time, it can quickly deteriorate and lead to persistent hypoxemia, respiratory failure, ARDS, and eventually death. There's some studies that suggest that it can have as high of mortality as 40% if it goes unrecognized for greater than 12 hours. So things to know in the PACU setting. It's obviously important to be aware of patients at risk of developing POPE. So again, young, healthy patients or patients with a long-standing obstruction. Maintain airway patency, bite blocks if a patient remains intubated, and then early recognitions of the signs and symptoms are key to rapid recovery. And then just some quick hitters to round things out. Again, rapid onset pulmonary edema. Type 1 is going to be immediately following acute episode of airway obstruction. Type 2 is going to be developing shortly after the relief of a long-standing chronic obstruction. Laryngospasms, the most common culprit. Significant frothy pulmonary secretions may be visible, but not necessarily, not always present. Early recognition and initiation of treatment can drastically improve outcomes. Treatment's going to be largely supportive with supplemental O's and PEEP, and most cases resolve within 12 to 48 hours. Those are our references, and that is our presentation. Any questions?
And I don't know if Dr. Davis had any insight for you guys. Have you ever seen this or had firsthand just giving you any guidance of oh yeah, I have this patient or whatever? weighed in about. We didn't review this with him.
Yeah.
You guys did-
I can tell you my experience.
Oh, I didn't know you're standing there.
The common things are like young, strong patients who have a lot of muscle or large obese patients. I think those that tend to have either a lot of obstruction or they are light in the OR and they bite on the tube. They have a bite block and they try to breathe against the throat. A lot is hitting down to big hydrostatic pressure closing the pulmonary edema. So it always seems to happen like once a year around here. And it's, staff stat in the OR, it's usually around emergence and extubation time at the case. And then, but it, certainly could happen here. So I don't know that I've witnessed the primary event happening here. Usually it's syphilis and something that happened in the OR and they're coming here. Usually we put them on some CPAP or BiPAP if needed. So they get that pulmonary pressure to push everything out. And I came in a little bit late, but did you guys talk about Lasix?
Yes.
Okay, so not great evidence.
No great evidence. No.
So do we give it now and then? Sometimes we do. I don't know that it really makes a difference. It's just time and everything just can settle out. And then of course underlying comorbidities will influence how significant or not significant the patient suffers from the sequela. Most of the time comes from people that are really you have to follow the clinical trajectory, but and see how severe it is. But in many cases, it might be extended monitoring positive.
Maybe they have after.
I mean, it's usually acute, and then after they get put on positive pressure, and then they're kind of watched overnight if they need to stay on positive pressure with the unit. You watch overnight. Usually nothing long term.
Thank you guys.
Thank you.
Appreciate it. You guys just sign in and please make sure you sign in.